There are a variety of intraoral radiographic techniques that can be learned, but the paralleling is one of the most common techniques that you will use as a dental radiographer. So in this module, we will talk about the paralleling technique and we'll talk about the patient preparation, equipment, the exposing sequence, film placement. All of this is the paralleling technique. And we'll also include a few modifications while using this technique to use with patients that have certain anatomical conditions. So let's get started with the basic concepts of the paralleling technique. This technique is also known as the extension cone paralleling technique, or XCP, the right angle technique, or the long cone technique. And there's a few basic terminology here that we need to discuss before we can move on to help you understand the paralleling technique a little better. So the first is the long axis of the tooth. This is the imaginary line that divides the tooth into two equal halves long ways. So basically it just splits the tooth right down the middle. This is the long axis of the tooth. And the second term is the central ray. This is the central portion of the primary beam of X radiation. So basically the main part of the beam that is doing most of the work here when we're taking the X-ray. So how does this paralleling technique work? I already did the slides, so I'm gonna keep clicking through. So how does this paralleling technique work? Principles. The film is placed in the mouth parallel to the long axis of the tooth. So you have to imagine that line running down the center of the tooth, splitting it in half long ways. The film will run parallel to that. Now remember that parallel means that two lines are going to run alongside of each other, and there's always going to be the same distance between the front of that line, those two lines, and the back of those two lines. So the film is always going to be placed parallel to the long axis of the tooth. Then that central ray is directed perpendicular to the film and the long axis. So think of that long axis as one line, and you want to take that central ray and you want to hit it dead on. You want to hit it at a 90-degree angle. That's what perpendicular is. It's when you have two lines that come together and they're going to make that 90-degree angle. And it is important that a film holder is used to keep the film parallel, since that's the whole basis of this concept is the paralleling technique. So if our film is not parallel, we're probably going to have some kind of error. And it is also important that the patient does not hold the film. We want to reduce the amount of X-ray, the amount of radiation that our patient is exposed to, so we cannot have them hold the film. So let's review here what this basically all means. So here we have our PID. Here we have the tooth, and this is the film. And this would be the film holder. Or as you can see, it's using the word receptor interchangeably as well. So we would have traditional film would be the film, digital sensor would be the sensor, but they are also known as the, they are also both known as the sensor. So with our tube head here, this CR, this is our central ray. So the tube head, the central ray is going to exit that tube head and it hits this tooth. The long axis of the tooth divides it in half. So it's going to hit that tooth and form this 90-degree angle and carry on and hit to the film, which is parallel to that long axis of the tooth. So if you look closely, you can see that these two, if they could continue to extend on and on and on and on, they would run parallel the whole distance of the line. And so that is the basics of the paralleling technique. And so I mentioned film holders. We cannot have the patient hold the film, so we have to have film holders. There's a couple different kinds that are available. Any way that you look at it, whatever one you get, it is a device that positions and holds the film in the mouth during exposure. This is so that patient does not have to hold it in place, or you do not have to hold it in place. And some examples we have here. We are going to have, I'm going to go edit that slide and then I will repeat it. So as I previously mentioned, the paralleling technique uses something called a film holder. This is a device that holds and positions the film in the mouth during exposure. This totally eliminates the need for anybody to hold the film, whether it's the patient or whether it would be the operator. We do not have to hold the film in the mouth. There's several different types of film holders on the market, but some examples are as follows. We have the RIN XCP instrument. This is a plastic bite block, a plastic aiming ring, and a metal indicator arm. This is, when using the paralleling technique, this is probably one of the most common systems for film holders. Some more examples, we have the precision film holder, which is a metal collimating shield and a film holder device. This is going to be beneficial because it also restricts the size of the beam to the size of the film. And then we have the Stabe film holder, which is a one-time use. It's typically made of some kind of styrofoam or low-grade plastic that can just be disposed of. The film used for the paralleling technique is going to be a size 1 when you're in the anterior region. This is a recommendation. Many places will use a size 2 for the whole mouth. But the reason for the size 1 is because the front of the mouth is a little bit more narrow. Teeth are a little bit smaller, so the smaller film is sometimes more beneficial for your patient. It makes it easier for them to tolerate. And in this case, the size 1 film is always going to be positioned with the long portion of the film in a vertical or upright direction. Another advantage to using a size 1 in the anterior would be that it is a slightly more narrow film and it's not going to bend as easily when your patient closes. And when we're exposing films in the posterior area, we are going to use a size 2, or that is the recommended size film. And when we use this one, the size 2 is always going to be placed with the long portion of the film in a horizontal position, or it's going to run sideways. There are 5 basic rules that you will want to follow when using the paralleling technique. And the first one is the film placement. The film must be positioned so that it covers any of the teeth that were prescribed to be radiographed. The second rule is the film position. It should be parallel to the long axis of the tooth and towards the middle of the oral cavity. It is placed more towards the middle of the oral cavity because of the way that the teeth are shaped, or the curvature of the palate. The object to film distance, or the distance between the film and the tooth, must increase so that the film can remain parallel with the long axis of the tooth. Otherwise, if you had it flush up against the tooth, if you had them touching each other, you wouldn't have so much you wouldn't have as much of a parallel between the long axis of the tooth and the film. That film might have a slight curvature to it based on the way that the mouth curves. The third rule is vertical angulation. The central ray is perpendicular to the film. Remember, you're thinking of that long axis of the tooth as the line you're kind of aiming for, and that central ray needs to hit it so that the two of them together form that right angle. The fourth rule is horizontal angulation, so that central ray passes directly through the contacts of the teeth. If it passes through the tooth at a slight angle, you're going to have an error appear on the film. So we need to make sure that it is straight through the contacts of the teeth. And the last rule is going to be film exposure. The X-ray beam is centered on the film to ensure all areas of the film are exposed. If it's not centered on the film, the X-ray beam will only capture a partial image on the film, and this is what we call a cone cut, or you will see a white area on the film. It'll be kind of rounded, and it can be produced with either a round or a rectangular PID. Once you have an understanding of these 5 rules, you're ready to move on and begin to take radiographs on your patient. So, for the procedures, first thing we need to do is prepare our patient. And we are going to do that by explaining the procedure, adjusting the chair, applying the lead apron and the thyroid collar, and remove any objects from the mouth. So you want to explain the procedure so that they understand what is happening. Why are we doing this? What is the purpose of this? Do we need to do this? Remember, there's going to be lots and lots of questions from certain patients. Adjust the chair. You want to make sure that chair is at a good level for you to be able to maneuver all of the equipment and get the best picture you can. Lead apron, thyroid collar, those are for protection, and remove any objects from the mouth, any retainers they may have, any piercings they may have. Those can all obstruct the view of something that we may need to see. It can alter the way that a tooth looks. So it'll cause an error on the film that we need to make sure we can eliminate by having them remove anything that may be in their mouth. And then we have the equipment prep. We want to make sure we have all of our exposure factors set correctly, and we want to open and assemble any of our instruments. From there, you will want to make sure that you have a sequence. You want to make sure that you know what order you're going in, so it's good for you to always start in the same place. And the recommendation is that you always start with the anterior teeth. One reason for this is because it's recommended that a size 1 film is used in the anterior region, so it's smaller and it's going to be less uncomfortable for the patient. It also lets the patient adjust to the film holders in their mouth. It's kind of bulky in there, and so some patients tolerate it well and some don't tolerate it as well. So doing the anterior first will help them adjust to having that in their mouth. And it's also less likely to cause a gag reflex. Goes back to that one before, lets patients adjust the film. It goes back to that one before. It lets the patient adjust to the film holders. So they're used to it being in their mouth, so it's less likely to cause that gag reflex because they know what to expect. And the recommended sequence is going to be as follows. You start with the maxillary right canine, working towards the left, ending with the maxillary left canine. So with a size 1 film, this is going to be 4 films. You'll have your maxillary right canine as 1. Then you will have the maxillary right lateral and the central on a second film. The maxillary left, central, and the lateral on the third film. And the maxillary left canine would be on the 4th film if you're using size 1. Once you've taken that left canine, you will then drop down to the mandibular. So you'll work your way across again with the mandibular left canine towards the mandibular right canine. And there would be a total of 3 films if you're using size 1 again. So you would have the mandibular left canine as 1, and then both centrals and both laterals would appear on the second film, and you would have your mandibular right canine on the last film. If a size 2 is going to be used instead, there will be 6 anterior film placements. You'll have 3 on the maxillary and then 3 on the mandibular. Doing it this way helps the operator stay on track. It helps the operator know where they're at, so there's not any accidental repeats and there's not any accidentally left out. After all the anterior are done, you can begin with the posterior teeth, and it's recommended that you expose a premolar first. Again, it is just easier for the patient to tolerate, and it helps them get used to that film placement in their mouth. So for our sequence, let me just redo that slide. Let me go back here and redo that slide. Once the anterior are completed, you can begin the posterior exposures. It's recommended to always expose the premolar first. Again, it's just easier for the patient to tolerate. It's less likely to cause the gag reflex, and it helps them get used to having that in the back of their mouth. For the exposure sequence here, we will have 8 posterior films to take. And the sequence is going to vary depending on the type of holder that you're using. So we're going to discuss as if we were using the RIN XCP instrument, or the XCP, which is the colorful rings. So to review here for the film placement, if I'm using a size 1 film for anterior teeth, which is where I'm starting at, there's going to be 7 total. I'll have 2 maxillary canines, 2 maxillary incisors, 2 mandibular canines, and 1 mandibular central. That one will contain both centrals and both incisors, both laterals. And then if I'm using size 2 for the posterior, I'll have 8 total, which will be 2 maxillary premolar, 2 maxillary molar, and then 2 mandibular premolar and 2 mandibular molar as well. Okay, redoing that slide since those last 2 bullet points were cut off. So to review our film placement, if we are using a size 1 film for the anterior, which is the recommendation, there are going to be a total of 7 films. And that's going to include 2 maxillary canines, 2 maxillary incisors, 2 mandibular canines, and 1 mandibular central that will have 4 teeth on it. So on that one film, you should have your right lateral incisor, both central incisors, and your left lateral incisor from the mandibular. Your left lateral incisor from the mandibular. And using size 2 film for the posterior, there's going to be 8 films total. You will have 2 maxillary premolars, 2 maxillary molars, 2 mandibular premolars, and 2 mandibular molars. Okay, let's try this slide one more time because it's still cut off. So to review our film placement, when taking exposures in the anterior region, it's recommended that you use the size 1 film, and there's going to be a total of 7. You'll have 2 maxillary canines, 2 maxillary incisors, and 2 mandibular canines, and 1 mandibular central. That one film should include your lateral central on both the right and the left, and then your lateral incisor on both the right and the left, and your central incisors from the right and the left. For posterior, if you're using a size 2 film, you're going to have 8 total, and that is going to be 2 maxillary premolars, 2 maxillary molars, 2 mandibular premolars, and 2 mandibular molars. Sometimes when you're taking a film, you will have a patient that has some abnormalities in their mouth, different anatomical structures. So we may need to make some modifications due to these anatomic conditions. Some of the conditions you may find that you have to make these adjustments for would be a shallow palate. You can use a bite block. Backing up, starting over. Sometimes Sometimes when you are taking a dental film, you will come across different anatomical conditions that may require you to have some modifications. And these modifications are what is going to help get the best x-ray possible. And one condition you may come across is a shallow palate. When a patient has a shallow palate, it is sometimes difficult for there to get that parallelism, or for the film and the long axis of the tooth to be parallel. It's difficult to get that when they have a shallow palate. If we use a bite block, it may cause tilting, which means that the film would not be parallel. So a bite block may tilt, causing film to be unparalleled. A bite block might kind of lift up one side of the film, and then it's no longer parallel with that long axis of the tooth. So one thing you can do is use a cotton roll to stabilize the bite block. You would place one cotton roll on either side of the bite block. However, periapical coverage is reduced. So that means we might see less of that periapical area by using this, but we may be able to get more on the film than we otherwise would if we had it, or wouldn't be as distorted if we hadn't used those cotton rolls. Another option you have is to increase the vertical angulation by 5 to 15 degrees. This will compensate for the fact that the long axis of the tooth and the film are not parallel. However, you still may end up with a few image distortions because now you are not using that correct angulation, and it will lead to some different errors that will appear on the film. The next condition is a bony growth or tori. If the tori is on the maxillary, it will be along the midline of the hard palate. So the film must be placed on the far side of this bony growth and then exposed. You may see on the radiograph then the border of the tori as a radiopaque area. If it is a mandibular tori, the film must be placed between the tori and the tongue. In either case, you never want to place the film on the tori. But with mandibular, you'll place it between the tori and the tongue. And also you may see some, again, you may also see some radiopaque areas. This is just indicating where the border of that tori may be. And so here's just a little example. You can see that film in this area right here. You will notice that radiopacity, and that is going to be tori. Another modification you may have to make is in the mandibular premolar region. It is an area that can be very sensitive, and especially when that film holder is placed, it can cause some discomfort for your patients. So, you will want to make sure you place the film under the tongue. This way, you're not kind of pinching that muscle attachment in the lingual area there. Or you can also curve the film gently. This isn't going to be the same as bending or creasing the film. This is just kind of softening the film so that it can be a little bit more comfortable for the patient. They also have some other things that you can use for this. They make these almost like styrofoam stickies that go around the edges of the film. And so it's like putting a cushion on the film so that when you place it in the patient's mouth, that cushion touches the flora of the mouth versus that actual kind of sharpness of the film. Some advantages to the paralleling technique. It is accurate. It has a high rate of accuracy. The image is very close to representing what the actual tooth looks like, and there is very little distortion, and it has dimensional accuracy. The simplicity of it. It's simple and it's easy to learn and it's easy to use. When you're using the film holder with the beam alignment device, so the colored block and then the colored ring, it's going to basically get rid of the need for the radiographer to determine your horizontal and your vertical angulations. So this is going to eliminate the chance of that distortion. So it really makes it so much easier for the dental radiographer. So the alignment device eliminates the need for the operator to determine horizontal and vertical angulation. And for duplication purposes, it's easy to get the same shot again with the paralleling technique if you are using your XCP correctly. It is much easier to take a similar shot when you are using that alignment device. Like everything that has an advantage, there are going to be disadvantages. Patient comfort can be a problem here, but we have ways to get around that. So the disadvantages are going to be the film placement. The film holding device can make it difficult to place the film sometimes. Sometimes it's bulky in the patient's mouth, so they use their tongue to try to push it out, and sometimes the ring is sliding off when you're trying to put it in the patient's mouth. So there's different obstacles that you have to overcome as a disadvantage, but this is a simple method, especially with children and those abnormalities that we've sort of discussed. It's going to be more difficult to get that XCP in a child's mouth than it is to do it in an adult's mouth. That's just one of the challenges that you will have to face. And then the discomfort. It's going to maybe pinch on some of those oral tissues and cause discomfort for the patient. But as I said, we can kind of get around that. We have different techniques that can be used. And with that little sticky styrofoam stuff that acts like a cushion, it's made it easy breezy. Let me back up. Let me do discomfort again. So the second disadvantage is going to be that discomfort. The film holder can press down on the tissues, it's going to pinch, it's going to make their tissue a little bit sore potentially, but we have ways around that. We have things we can use. And with the Styrofoam sticky tabs that act like a cushion, that is almost eliminated. And the other part of that is the gag reflex. It can cause that patient to gag if they first time they've ever had the XCP in their mouth, or if they just have a sensitive gag reflex. And that concludes the paralleling technique. So let's review. What size film is used when using XCP instruments to take posterior radiographs? A, size 1, B, size 2, C, size 3, or D, size 4? The answer is going to be B, size 2. Which of the following describes the relationship of the film to the long axis of the tooth using this same technique? A, the film and the tooth are parallel to each other. B, the film and the tooth are at right angles to each other. C, the film and the tooth are perpendicular to each other. Or D, the film and the tooth are intersecting each other. And the correct answer is A. The size, let me edit that one. The correct answer is A. The film and tooth are parallel to each other. Which of the following is correct regarding film placement? A. Anterior films are placed horizontally. B. Anterior films are placed vertically. C. Anterior films can be placed either horizontally or vertically. Or D. There are no anterior films for the paralleling technique. The correct answer is B. The films are placed vertically when taking an anterior radiograph. And last, which of the following is correct regarding film and tooth distance in the paralleling technique? A. The film is placed away from the tooth. B. The film is placed as close to the tooth as possible. C. The distance between the film and the tooth does not matter as long as the angle is correct. Or D. Either A or B. The correct answer is A. The films are placed away from the tooth due to the curvature of the mouth.